introducing our panel of speakers today. Start with Liz Faris here. She's our moderator. Liz Faris leads the lifecycle development, project management, and budgeting of North Range Behavioral Health Electronic Medical Record, or EMR, for both clinical and business departments. Data reporting is also a critical area of concentration in state reporting and submission requirements. Liz gets to oversee everything technology and everything that gets tracked, so she has a really big job. Next to Liz is Magda Turner. She's a human resources coordinator at LifeStance Health. She comes to the mental health industry with a background in HR compliance in the specialty construction industry. Magda obtained her undergrad in business administration at the University of Colorado, Denver, and a master's degree in human resources management from Colorado State University's Global Campus. Next, we have Han. He is a recovery coach and peer professional at North Colorado Health Alliance. Hans Pearson is 2 years in recovery, congratulations, and has a passion for sharing his experience and hopes that his story can inspire and encourage others to succeed in their own recovery. Next, we have Christopher Aguilar. He is a recovery coordinator at the Department of Veterans Affairs, a social worker with 14 years of experience working with veterans, families, and children. Christopher is experienced in providing and supervising teams in both clinical and administrative roles. He has a strong focus on community and organizational program development. And he says that working with peer support specialists is my favorite work I've ever been a part of. And Liz Eames, at the end of our table, Liz is the director of early childhood mental health and the Early Childhood Council of Larimer County. She has more than 10 years of experience working in nonprofits with an extensive background in program development, event management, grant writing, community collaboration, system levels improvements. She's currently pursuing her Master's of Nonprofit Management degree from Regis University and has a bachelor's degree in political science from Larimer College. This is our incredible panel. Thank you all for being here today. And if you want to take it away.
Thank you, Jill. Thank you so much, Jill. Appreciate your help.
Yep. Yeah, it's good.
Good. All right. Thanks, Jill. Appreciate your help with the microphone and having us all here today. And again, I want to extend a great thank you to the individuals here on the panel with me for the support roles. You know, we often are in the background. We are often the magic behind the curtain. And I think for me, I just want to say a couple of words, and then I'm going to turn it over to Magda here. Right. I think it's a great opportunity to be in healthcare and see it from the backside. Electronic health records, you know, we have to put it all together so the clinicians can do their great job working with the providers, other providers, clients, and making sure that they get the care that they need. The EMR and data services area, you know, we have such a variety of things that we accomplish, from bringing data forward into visualization tools. We use a tool called Tableau, and it often tells us an incredible story about how the agency is doing in regards to our clinical outcomes and the number of services that we're providing. In the electronic health record world, we have to make sure the claims go out clean and that we get payment back in accordance to the rules and regulations of not only Medicaid, but also Centers for Medicare. It's an ever-changing world. And I think what I appreciate most about it is the fact that I know I can make an impact to help the providers do the job that they do in their work with the clinicians. Oh, Magda, tell us your story.
Sure. It's kind of a long story, but long story short, I come to the mental health care industry from construction, so it's very new to me, but very dear to my heart, and it impacts my life personally because I have two of my three children that deal with multiple mental health concerns, and so just how difficult it is to get good care and take care of them has really taught me the importance of mental health care in our society, and especially during the pandemic and everything that's been going on. That really drew me to want to support the mental health care providers that do such good work for us, and that's what drew me to LifeStance Health. I work on the back end, like you mentioned, just to make sure everything runs smoothly for them, so they don't have to worry about many of the things that wouldn't even come to mind that goes into making a company run smoothly, efficiently, and be able to provide that care to people that is very needed. Yeah, that's what brought me to mental health care.
I think I'd love to know more about a challenging opportunity that you have overcome in your HR role with your LifeStance.
Yeah, I don't know that I've come across anything challenging from the professional side of it, but from the personal side of it, I was recently diagnosed ADHD, and I just realized that a lot of the ways that I cope in my life were due to not being diagnosed, and it has made such a change to me personally and professionally, the way that I work, the way that I structure my day, the way that I support people in general has been a huge challenge to overcome, and I've seen a lot of benefit from it as well. So I really enjoy being able to bring that to other people. Even though I'm not a mental health provider, I can still help in the ways that I know how to.
How many people do you support at LifeStance?
Well, currently I'm in the Colorado division, so just all of our Colorado offices. I believe we have 30-something-ish offices, 100 providers, I want to say. And so I'm kind of like the first line of contact for many, many issues, including benefits, pay, a lot of different employee relations topics, and just kind of helping sort through all of that.
What will be one of your initiatives this year through the Human Resources Department?
That I'm not totally sure. Currently, my role might be changing more towards employee relations. So my goal is just to try to help managers and clinicians really have better relationships with each other so that they can best serve their clients.
Thank you. Yeah, you're welcome. Sharing.
Hello, thank you for the opportunity to be here and share my story. My name is Pearson. I'm a peer specialist for the North Colorado Health Alliance. And what a peer is defined in Webster's as being eye to eye. So we provide a level of security, a level of trust and connection with our clients, specifically those who are struggling with addiction. So I work for the COSLAW organization, which is addiction response. It's Colorado Opioid Synergy with Larimer and Weld, working on the synergy part. But we are making strides in what it is for people that are seeking recovery and being able to open up options for treatment services. I first entered this type of work, the behavioral health and recovery work, because I was struggling with addiction myself. I had a year of sobriety, and somebody that asked me about a position for NCHA, which was their pioneer role as a peer specialist. So nobody knew exactly what that would look like. So I took my experiences in my life and in addiction, and they just gave me this extreme autonomy and just this wide open playing field to develop this position. And what I found was there's so many needs for peers in all different types of clinical and non-clinical work. For example, right now, there's a young man who I know who's struggling with addiction, who has ODD, which is opposition defiance disorder. So he doesn't like to talk to a lot of people. So what I do is I attend doctor's appointments, and I've helped advocate for him. You know, I have a child who's 13 years old, and when the waiter comes to ask him what he wants to eat, he still leans over and tells me what he wants to eat and then I tell the waitress. So think about that in the sense of a client who's not comfortable speaking to their doctor. They don't know how to voice what they want or what they need because they're intimidated by the clinician. They're intimidated by any type of authoritative role. So as a peer, we try and bridge that gap that may exist between clinician and patient. So it's being able to speak out for what they need, and then just trying to create a voice for people that are silenced, and creating a beacon out of people who maybe not being seen. So my story just fit perfect into this line of work. And from here, the cool thing is that it's just opened up 1,000 opportunities in which direction for this career to head. You know, they pay for all my certifications, all my trainings. They're paying me to sit here in front of you now. So there's so many great things that come from finding an organization that's willing to take a risk on somebody who is looking for a second chance. So, you know, through NCHA, through COSLAW Network, through working with North Range Behavioral Health, Summit Stone, the recovery services that are sitting out there promoting their places like Harmony Foundation and North Point, those are all great people that have been assets in my line of work. But yeah, thank you.
Hans, if you could, tell us a little bit about the certification and the training that you received to become a peer specialist.
So it's pretty simple. There's a small exam. I do supervision hours with Michelle Simons, who oversees the Signal grant. So there's you know, a few things you have to do here. There's obviously educational hours, but they're very reasonable. And like I said, through NCHA, they've put a bill for all my education so that they can better serve their community. So it's such a mutual relationship and such a mutual gain. The next thing we're working on is finding funding for language training. That's where we're finding the largest gaps in cultural differences.
And would that be possibly hiring another peer specialist who is Spanish speaking?
Absolutely. What we're finding is that there's just not enough there. So what do? You know, we plan for a future, and we start empowering students. We start empowering our youth and teaching them, you know, that just because you're a Spanish-speaking background doesn't mean you need to work in construction. And, you know, it's just, you know, opening that door for behavioral professionals, because this was an entry-level position, and anybody could have the heart for wanting to help somebody to join.
One of the things you told me earlier was about the catchment area that you cover. You mentioned you go all the way up to Estes Park, you work in mainly Larimer County. Tell us the differences between Larimer County, you know, with Loveland versus Estes Park. What are the things that you've seen differently between those two towns?
Well, it's not so much just the demographic difference. Like Estes Park has, it's a strange community where a lot of the city council and government officials are Caucasian, and the community is largely Hispanic. But working in the high school is different because we're running into, for example, a young girl I was working with who had experienced alcohol poisoning. So addressing those things with adolescents and preventative maintenance, as opposed to we're distributing Narcan in larger cities like Dublin and Fort Collins, and working with large transient populations, and how can we get them sustainable housing or sustainable recovery, or, you know, at least if not, we're trying to create an awareness to keep them alive. So it's very different, but it's a lot the same. But it showed me that there's a need for this type of application all over the map.
In a week's time, how many clients do you usually work with?
It's hard to say because there's people that put in a lot more follow through work. Like there's a couple of care managers for some folks sitting over there that I work with, and I have kind of a more of a light touch where it's an introduction. Are you comfortable? Let me set you up with a care manager who can follow through with your needs. So I mean, sometimes it's several a day, and sometimes it's one a week, depending on how involved the care is needed. I have one particular client that I'm working with right now that just requires a large amount of time and a large amount of energy. And we try and keep it open for everybody that needs service to get the service. But there's those particularly needy clients that we go out of our way for in attending their doctor's appointments, attending court with them.
So you talked about some great successes. Can you describe one of the challenges that you had working with clients?
Oh yeah, so working with youth, and that doesn't necessarily mean 15, 16. We're talking like 17, all bordering on 18, and finding programs that will accept them because they're almost too old for the adolescent programs, but too young, and so it starts to become an issue of policy. And so what I found is that policy has been a barrier for treatment for certain individuals because we're unaware of the gap. So I tell you what, if there is a roadblock, I've found it, and it's been working with adolescents with dual diagnosis.
In your opinion, what would be the best way to remove those roadblocks or barriers for the adolescents, the older adolescents?
Well, not treating them as adolescents. A lot of them are autonomous on they're on their own already, and just because they haven't reached that age, they're treated in a different way when their problems don't differ from 17 to 20, but the treatment that they're allowed to receive does. So I mean, what we can do, we have so many conversations, we have so many forward-thinking conversations about harm reduction, about what type of services we can provide. But our conversations are ahead of our actions. And so just catching up to what we say behind closed doors and bringing that out to our public, to the clients that we serve, because we love to say that I can help you, but in reality, right now, I'm working on a client that has been turned down at every facility that we've tried to get them into. Part of it is their behavioral problems. Part of it is we're finding racial barriers. We're finding age barriers. It's just time to catch up with what we're talking about.
Thank you. Thank you. Appreciate you telling us your story.
Thank you.
All right, next we're going to hear from Chris Aguilar. And I think that one of the things I'm most excited to hear from Chris about is the fact that he works with veterans. Veterans in my family are very strong, and I have several family members that have served. So thank you for doing the work that you do.
Yeah, it's my pleasure, and thank you for having me. A little bit of how I got into this line of work. I decided I want to be a social worker probably somewhere in my mid-20s. First started working with children, youth, and family for Larimer County. Spent some time working with child protection, juvenile assessment. My passion at that time for working with that population was because I come from a huge family myself, and anyone from a big family knows that you get to see a lot of dysfunction sometimes, and of all kinds of flavors. But I never went to bed hungry, and I never was afraid of not having shelter. So I understood kind of the realities that I was witnessing, but also how good I had it too at home. So working with children, youth, and family was good for as long as it lasted. Later in my 20s, I got this passion to work with veterans because my mother at the time was 52 years old and just got her orders to Iraq on a medical detachment unit. I was in my mid-20s, like I said, and I was kind of drifting a little bit. And so it really ignited a fire to go further, get my master's. And really, I had my sights set on the VA from day one. That's how I ended up at VA. I spent my first several years as a direct therapist. Some of the most valuable and lifelong lessons I've learned was sitting in rooms with veterans, having them tell me their stories day after day, week after week, month after month. I learned a lot, I gained a lot, but as life would take it, I transitioned to another role that I felt more suited for and felt more at home with, and that is more of a program coordinator, more of a program manager, as you were stating, behind the scenes, kind of directing traffic, supporting the people literally on the front lines to do their job, and taking every advantage that I could to alleviate the struggle and the pain and the challenge that they deal with on a daily basis. And I'm not just saying the work they do, but I'm also saying working for the federal government as well. There's a lot of headaches sometimes. There's a lot of bureaucratic red tape. Anyone who works for the federal government would agree. So I take a lot of pride working with peers. It's, again, my favorite thing I've ever done. Peers come with a passion that is undeniable. And really a big part of my job is holding the reins back because they want to do so much and they bring so much of that lived experience in helping others. And so that's kind of how I evolved to where I am right now. And even with the struggles and the challenges and the headaches, sometimes it is a lot of fun and a lot of pride I have in what I do.
Can you tell us about your education background? Where did you do your undergraduate? Was it in social work as well? And then your master's degree was obtained from which university?
Yeah, so that's the benefit of starting college in a non-traditional year. So I got my undergrad at CSU, and I had plans on going on to my master's there at CSU as well. So I knew the end goal, literally right when mom's orders. I knew I wanted to be at the VA. I grew up with a father who is a Vietnam vet, PTSD, long history of addiction. And I used to go with him to the Denver VA. We used to drive up from Pueblo once a month. And it was a scary place, a really scary place as a young child. And so that combined with the orders that mom just got, really the combination of the motivation was all I needed. I knew I wanted to be a social worker at the VA. So CSU provided that path. And when I got there, I talked with my field placement coordinator, and when it came time to pick out an internship, I said, really, I got the VA is really all I want. And if we can't make that happen, then I'll travel to another VA. If Cheyenne can't make it happen, I'll go to Denver, I'll go to Grand Junction, I'll do whatever I have to do. So luckily, I was able to intern at the Cheyenne VA and got hired on.
Are you still at Cheyenne, or are you in a VA clinic here locally?
So the local clinics are satellite clinics of Cheyenne. So I still work for the Cheyenne VA. I was just sharing with some folks over there that the Loveland area is going to have their second very large outpatient clinic opening this spring, I believe. So I'm a remote worker. I've been working remote long before COVID. I know everyone here deals with space issues, of course. The VA has been dealing with space issues for a very long time. So a long time ago, those of us who are more coordinators and managers got pushed out of the brick and mortar space, and we're working from home. So yeah, I serve, and my team serves the veterans of Larimer County, Weld County, Northern Boulder County, and a large portion of northeastern Colorado, of course, southeastern Wyoming, and southwestern Nebraska. That's our catchment area.
Are you providing supervision to any other therapists through the VA?
I have in the past in other roles, but right now it's just the peer support team.
Thank you so much.
Yeah.
Hello, everyone. My name is Liz Hayes. I'm from the Early Childhood Council of Larimer County.
I'm the early childhood mental health director there, and I have no background in mental health. So I was excited to be asked to talk on this panel today because how I fell into this role was a little bit non-traditional, like all of us up here. But you really can make a huge impact without even studying behavioral health, if that's the route that you decide to go. My background was in political science, and I knew I didn't want to work in campaign politics or on the Hill, Washington, D.C. I had a passion for nonprofit work and social justice issues. And so really I approached it more from the program development lens and advocacy and promotion. And that's how I fell into early childhood mental health. At the time, there was not an early childhood mental health program in Larimer County. Rather, there was sort of a grassroots coalition of many organizations and people that wanted to do more in this space, but didn't really have a plan in place. So they came together to create the LEAP Coalition, and I was hired on as the coalition coordinator for that. That was about 3 years ago. In that time, the program has grown from one staff person and less than $25,000 to 7 staff people and over $500,000. We're now a dedicated program under the Early Childhood Council. So we've seen huge growth in that. And that has been, thanks in part to my background in program development and being able to bring different skills to the table, not just direct service, but like I said, program management and then grant writing and communications and advocacy. So,
so with your grant writing, what has been your most proudest moment in one of the awards that Early Childhood Development Center has received?
sure. So in a couple of years ago, 2018, I think, Larimer County passed a ballot initiative 1A that developed a sales tax, to fund the Larimer County Department of Behavioral Health Services. So they created a new department within the county. And as part of that, there's a community grant fund. And in the second year, we were awarded over $180,000 to support the early childhood mental health program. And that was the largest award that year. And it was their first big year of giving out funds. And to have the county commissioners and others recognize early childhood mental health as a main player in the mental health field was a really big deal for us. That funding went on to support a innovative internship program that we got started with the CSU School of Social Work, which does not have an early childhood track. And so in lieu of that, we have set up an internship that pairs students with all sorts of different community partners working in early childhood mental health, and gives them a really well-rounded view of all the types of jobs that you can have in that, not dissimilar from this panel. So direct service, but all the way to like policy and advocacy.
One of the other things I noticed in your bio was the fact that you have coordination of workforce development projects. All of our companies are struggling right now with being able to hire employees. What has your organization done to recruit and maintain that you currently have?
Yeah, so that internship program with the CSU School of Social Work is a big one. We struggle with that too. Mental health in general does, but early childhood mental health, which focuses on 0 to 3 to 0 to 8 and fraternal mental health. There's just really not a lot of people who focus on that age range. And so building that career pipeline to get people from students, we do both PSW and MSW students. So just to get them interested in the field, know that this is a thing, this is an option that they can explore. As part of that internship program, we provide them with a stipend, the infant mental health endorsement through Colorado Association of Mental Health,
and training, the ability to share their internship hours among different sites. And so in return for all of that, we asked for a 1-year letter of service agreement to find work in Larimer County. So that's one way. We provide a lot of trainings in the community to increase both the breadth and depth of knowledge that people have about early childhood mental health. We also currently support over 40 professionals around the community to go through the infant mental health endorsement process as well. So we're taking, throwing everything at it, basically from all angles, kind of what we have to do, get people into the field, and then increase the level of knowledge that people have who are already in the field. You talked about some of the challenges in early childhood development, mental health. Is there anything specific that comes to mind that you want to share with the audience to say, hey, this was really an issue, a large barrier, and this is how we overcame it? I think the most important takeaway that I've learned when it comes to mental health, and the thing I always want to drive home, is that a lifetime of mental health begins in early childhood. Early childhood services really are primary prevention strategies. And so if you want to address addiction, suicide prevention, homelessness, all the things that we run into down the line, you can have a huge impact by starting in the earliest years, by focusing your resources on disrupting the intergenerational cycle of trauma. So that's one big takeaway. And how we're, there's so many different barriers because we work at the systems level, which means we don't provide direct service necessarily, but we're working to impact the entire early childhood system, the entire mental health system. So I think what has been really successful for us is that this program, like I said, started as a grassroots coalition. And so having community buy-in and have everyone, a lot of players in Larimer County feel a shared sense of ownership over the work has enabled us to take it as far as we have. Let's check out.
107.
So we still have a little bit of time left, about 8 minutes or so. We go to 1:15. Are there any questions from the audience here in the room? Or yes?
So I have a few questions in a short time. I do have one question. I over the years had ready to work in the disability community, physical and mental. And some of these services, I've heard of, the main complaint is not enough funding. Disabilities as a whole, physical, but when it came to mental, they say we're short over the years. And I was wondering why the rest of the disability has generally has enough, but the mental part doesn't. Why?
I want to start by saying I think that we're just now getting to the place where mental health is seen as whole health, not just physical health.
Yes, sir. If we look back at the way I grew up, is my dad would have referred to these conversations as touchy-feely, or so there's a stigma in that generation. So all the funding and all the stuff that's going on with mental health, this is new money. These are new as far as the last decade or so. But the more that we explore mental health, the more that we explore behavioral health, obviously there's a higher need, and when that's brought to light, then the funding comes. And the sad thing is that you can't address a problem until it's a problem. You can't fix something on your car that's not broken. So once there's this awareness of that there is such a need for mental, behavioral, and substance health, that's when we start to see funding, and then the problem doesn't become funding; it becomes providing services with the funding. So it's a constantly evolving picture that is always going to need maintenance. It's just like everything else, you know. It's just it's a struggle to keep up with the money we're given and to keep up with the grants that we're asking and to keep up with the services that we're providing.
Yeah, I think the only thing I would add, and those are two great points, is I believe the medical field, in a way, have long been the gatekeepers for patients receiving or clients' population receiving mental health care. And I'll just use the example of the VA is, you know, we have been long approaching this model of primary care mental health integration, where we have mental health providers within a primary care setting. So when the doctor or the nurse practitioner or the primary care physician is helping a patient and a behavioral or mental health issue comes up, they're not sitting there with lack of options. They're not sitting there with lack of a professional to go to and ask for help. But it really does take, I believe, those folks in the medical side to pound the table saying we need more mental health resources for our department, for our agency, for our hospital, et cetera, et cetera. In my experience, I think that has a lot to do with making those services more accessible and available, and in a lot of cases, financially reasonable too.
So I was just going to add that I think there's also a piece to it that a lot of mental health issues or concerns aren't really apparent. I think that with a lot of physical disabilities and stuff, it's kind of easy to see. And so it's more easy to address it. Whereas with mental health concerns, it's more invisible. And sometimes people don't talk about it because of that stigma. It's not brought up, it's brushed under the rug, or in my parents' generation, it's not real, it's made up. And I think that that is a major hurdle to getting the mental health care that people need, because we're trying to convince a whole generation or more that it's real, just because you can't see it.
You know, last night, President Biden spoke to the State of the Union. And one of the things that I took away from that was the fact that I was appreciative of the fact sheet that came out today regarding the funding that he was going to hopefully make available for the mental health crisis. A couple of those things that I thought were really important was the fact that they want to start a pilot program to diverse the paraprofessionals, to involve more funding, up to $225 million is what he has stated that he wanted to set aside for paraprofessionals and peer training. Another item was the fact that training programs, workforce, they're going to invest $700 million into the workforce for behavioral health training. So that made me feel very optimistic, and I hope that some of those things can come about for all of us that work in this field. I think in closing, I just want to thank the panelists here today that have been here for the organizational support roles, for all of you that are in the audience, from UNC, from AIMS, from CSU. Thank you for coming out today and joining us for this great opportunity to learn more about the behavioral health.
We'll give some closing remarks. Thank you again, panel. We hope that you've been inspired to learn more about the field, what pathways appeal to you, and how to continue your journey. There are QR codes to our survey on the tables. You will also receive an email. Please take some time to take our survey. We do have some drawings. We've got some baskets that we'll be giving away. So there's some incentive to take the survey, and we just definitely appreciate all of your feedback. Because as we do this every year, we want to hear from you. I also want to say again a special thanks to our event sponsor, Larimer County Behavioral Health Services, and then also our breakfast sponsor. And I apologize for not saying this in the opening this morning, but North Point, Colorado is our breakfast sponsor. So special thanks to all of our sponsors and all of you for a great event. Thank you so much. Have a great afternoon. Oh, it